If you have started a blood pressure medication in the last few years, and since then you have felt in ways you struggle to put into words, like a slightly different version of yourself, less energy than you used to have, sleep that doesn't restore you the way it once did, food that tastes somehow flatter than you remember, a low hum of anxiety that wasn't part of your personality before, you are not imagining it. It is not aging, and the cause is almost certainly not on your prescription label. There are four main classes of blood pressure medication, and each one depletes something different from your body, a different nutrient, a different biological system, a different set of symptoms that gets blamed on everything except the real cause. I'm Dr. Richard Ben. In the next 10 minutes, I am going to walk you through all four. The science behind each depletion, the warning signs to recognize in your own body, and the exact words to use with your doctor at your next appointment. Stay with me, because one of these four is almost certainly happening to you right now. Before I take you through each medication class, I want to tell you something that reframed how I practice medicine. Drug-induced nutrient depletion is not a fringe theory. It is documented in pharmacist textbooks, peer-reviewed journals, and clinical drug-nutrient interaction literature around the world. Here is why it happens. Medications work by interfering with specific biological pathways. But pathways don't carry only one thing. They carry whatever travels that route. Think of it like closing a road in a busy city. The road you closed was carrying the traffic you wanted to stop, but it was also carrying everything else traveling that way. Your body is not broken when this happens. Your medication is doing its job. It just has consequences that never made it onto the label. Now, let's go through each one. Medication Class 1 diuretics, also called water pills, the most commonly prescribed first-line blood pressure treatment. You may know them as hydrochlorothiazide, chlorthalidone, or furosemide. What they deplete: magnesium, potassium, and zinc. Diuretics lower blood pressure by prompting your kidneys to flush more fluid from your body. Less fluid volume in your blood vessels, less pressure on their walls. It works. But your kidneys don't flush selectively. Magnesium leaves, potassium leaves, zinc leaves. With every dose, every single day. A 2018 study from the Rotterdam study, one of the largest and longest-running cardiovascular research programs in Europe, following nearly 10,000 people, found that thiazide diuretic users had almost 3 times the risk of developing low magnesium levels compared to people not on the drug. Almost 3 times. Now, here is the detail I want you to hold on to. Magnesium deficiency raises blood pressure. The very mineral your diuretic is washing out every morning is one of the minerals your body uses to keep blood pressure in check. A 2025 meta-analysis published in Hypertension, one of the field's most respected journals, found that magnesium supplementation significantly reduced systolic blood pressure in people with hypertension who had low magnesium levels. The medication is working. The depletion may be quietly working against it. Both can be true at the same time. Warning signs to watch for: leg cramps that wake you at night, sleep you fall into but cannot sustain, heart palpitations with no clear cause, anxiety that arrived alongside the prescription, and constipation that appeared quietly and will not leave. For potassium depletion, unusual muscle weakness, fatigue, and in more significant cases, irregular heart rhythm. What to eat: pumpkin seeds for magnesium, roughly 156 milligrams per small handful, confirmed by USDA data. Bananas, sweet potatoes, and white beans for potassium, shellfish and lean red meat for zinc. And ask your doctor specifically about red blood cell magnesium, not serum magnesium, which only reflects about 1% of your body's total stores. Now, the second class. And this one has a symptom so specific, so quietly disorienting, that most patients blame themselves for it. Medication Class 2, ACE inhibitors, lisinopril, enalapril, ramipril. One of the most prescribed classes of blood pressure medication in the world. What they deplete: zinc. The mechanism is worth understanding because it is specific. ACE, angiotensin-converting enzyme, is a zinc-dependent enzyme. The drug works by binding to it and blocking its activity. But in doing so, it locks that zinc in a form your body can no longer use for anything else. Over months and years of daily use, a gradual loss of zinc from your body's tissues accumulates. The effect is best documented with captopril and has been consistently observed with enalapril. Clinical pharmacy literature classifies this as significant when the medication is used for 6 months or longer. Zinc drives over 300 enzymatic reactions in your body, your immune response, your wound healing, your ability to fight minor infections, and your sense of taste and smell. That last one is where patients almost always first recognize the pattern. I had a patient I will call Patricia, 62 years old. She came to see me 8 months after starting Lissopril, not about her blood pressure. That was well controlled. She came because food had stopped tasting the way it used to. Not dramatically, gradually. Coffee tasted flat. Chicken tasted of almost nothing. She had started adding more salt to everything without fully realizing why. She had lost 4 kilograms, not from dieting. She simply was not hungry anymore. Her previous doctor had noted the weight loss in her chart. No one had connected it to the prescription she had started 8 months before. I asked her one question. Has anyone mentioned zinc to you in the context of your medication? She looked at me the way Arthur had looked at me when I asked about magnesium. No, she said. Not once. We adjusted her diet, added zinc-rich foods consistently. Within 6 weeks, she was back at the table, eating properly, with appetite. Warning signs of zinc depletion, dulling or loss of taste, slow wound healing, minor infections that recur more than they should, and a quiet, unexplained decline in appetite. What to eat? Oysters are the single richest food source of zinc on the planet. One serving delivers more than most adults need in a day. If oysters are not practical, beef, crab, pumpkin seeds, and chickpeas are all clinically meaningful sources. One caution, do not supplement zinc at high doses without your doctor's agreement. Excess zinc depletes copper, which creates a separate and serious problem. Now, the third class. And this one explains an experience so common among people on this medication that most doctors now accept it as an unavoidable side effect. They are wrong about that. Medication class 3, beta blockers. Metoprolol, atenolol, propranolol, carvedilol. Prescribed for blood pressure, heart rhythm, and heart failure. What they suppress? Melatonin. And this is the one that explains why so many beta blocker users cannot sleep, and have been told it is simply something to live with. Here is the actual mechanism. Melatonin, your sleep hormone, is produced by the pineal gland in your brain. It is triggered each evening by signals traveling through beta-1 adrenergic receptors. Beta blockers work by blocking those receptors. That is precisely how they lower your heart rate and blood pressure. But those same receptors are the pathway through which your brain receives the signal to release melatonin after dark. Block the receptor and you block the signal. Block the signal and melatonin production falls. This is not speculation. A randomized, double-blind, placebo-controlled crossover study published in the European Journal of Clinical Pharmacology directly tested propranolol, atenolol, and carvedilol and measured their effect on nocturnal melatonin levels. All three reduced melatonin release via specific inhibition of beta-1 adrenergic receptors. A 2025 systematic literature review confirmed the same mechanism and noted that sleep disturbances are a recognized, well-documented consequence of beta blocker therapy. Not an occasional side effect, a predictable one. And there is a detail inside this that most people never hear. People with high blood pressure already produce less melatonin at night than people with normal blood pressure. Even before any medication, the beta blocker adds a second layer of suppression on a system that is already running below where it should be. If you take a beta blocker and you cannot fall asleep easily, or you wake repeatedly through the night, or you surface from sleep feeling like you barely went under, your prescription is very likely directly responsible. Warning signs: difficulty initiating sleep, waking at 2 or 3 in the morning, vivid or disturbing dreams, daytime fatigue that more sleep does not seem to fix, and a general sense that sleep is no longer doing what it used to do for you. What to do? Low-dose melatonin, between 0.5 milligram and 1 milligram, taken 30 minutes before bed, has shown measurable benefit in beta blocker users. This is a conversation to have with your doctor, not something to self-prescribe without guidance, but it is a studied, peer-reviewed intervention, not guesswork. For food, tart cherry juice. A 2024 meta-analysis published in Frontiers in Nutrition found that consuming Montmorency tart cherry juice twice daily for 7 to 14 days improved total sleep time and reduced sleep onset latency in adults with mild insomnia. A separate 2025 systematic review confirmed that 3 out of 7 interventional studies reported significant improvements in melatonin levels and sleep quality after tart cherry consumption. A small glass in the evening, simple, evidence-based, low risk now, the fourth class. I want to be more precise here than with the others because the evidence is different, and honesty matters more than a clean narrative. Medication Class 4, calcium channel blockers, amlodipine, nifedipine, diltiazem, verapamil. Widely prescribed for blood pressure and certain heart rhythm conditions. What they may affect, potassium. And here I want to be direct with you about the evidence. For the first 3 classes, the depletion mechanism is well defined and supported by controlled trials. For calcium channel blockers and potassium, the effect is noted across multiple clinical pharmacology sources and drug-nutrient interaction handbooks. But the mechanism is less precisely mapped, and the effect varies considerably from person to person. I tell you this because I would rather give you an honest picture than a tidy one that overstates what we actually know. What it means practically. If you take a calcium channel blocker and you notice muscle weakness, unexplained fatigue, or irregular heartbeat, potassium is worth raising with your doctor. I had a patient on amlodipine for 3 years who described her legs as feeling heavy. Her exact words were like walking through water. Her GP attributed it to age. We checked her potassium. It was at the lower end of the reference range. We added potassium-rich foods consistently. Within a month, she described her legs as her own again. Warning signs of low potassium, heaviness or weakness in the legs, unexplained fatigue, constipation, and heart palpitations. What to eat? Bananas are the most recognized source, but a medium sweet potato actually delivers around 540 milligrams, more than a banana, more versatile and more filling. White beans, lentils, avocado, and spinach are all strong contributors. Aim for variety rather than depending on any single food. Now, let me bring this together. I want to be clear about what this video is and what it is not. It is not a reason to stop your medication, not even close. Hypertension is the single largest modifiable risk factor for stroke and heart disease. The medications that treat it are among the most evidence-based tools in all of medicine. If your doctor prescribed one, that decision almost certainly saved you from something worse. What this video is the conversation your prescription never had with you. The one that allows you to walk into your next appointment and say, I take a thiazide diuretic. I would like to check my red blood cell magnesium and my potassium. Or I am on lisinopril, and food has been tasting different for months. Can we talk about zinc? Or I have been on metoprolol for 2 years and I cannot sleep the way I used to. I would like to discuss whether melatonin is appropriate for me. Those are specific, informed, actionable. They are not confrontational, they are not self-diagnosing. They are the questions of someone who understands their own body well enough to be a genuine participant in their own care. This week, one action. Look up which class of blood pressure medication you take. Match it to what you heard today. Add one food from that section to your shopping this week. Write down one question for your doctor. One food, one question. Your medication is doing something important. You deserve to make sure nothing is quietly unraveling while it does. Now, one more thing, and this one builds on everything we have covered so far. In this series, we have looked at statins and CoQ10, diuretics, and magnesium. Today, 4 blood pressure medication classes and what each depletes. In my next video, I am covering the medication that may be the most overlooked offender of all. Acid reflux medication, omeprazole, pantoprazole, proton pump inhibitors, PPIs. These drugs do not flush nutrients through your kidneys. They do something more fundamental than that. They change the pH of your stomach, and in doing so, they dismantle the chemical environment that your gut needs to absorb certain nutrients in the first place. You can eat perfectly, you can supplement carefully, and still, on a PPI, certain nutrients pass through you almost entirely unabsorbed. One of them is vitamin B12, and B12 deficiency in its early stages produces symptoms that are clinically very difficult to distinguish from the beginning of cognitive decline. Memory gaps, confusion, fatigue that sleep does not touch, a sense of mental slowing that everyone around you is starting to notice. In some patients, it has been misattributed to dementia, and it is reversible. If you or someone you love takes a PPI every morning, that video is not one to skip. Subscribe now. Hit the notification bell. I will see you there.